So at this point, before we all leave, I think it's important for us to go around once and give each of you just a few moments to give our audience some takeaway that's important to you. So why don't we start with Dr. Gerding?
Well, I think as you look at the new C. difficile guidelines, 2 points I think for general practitioners to know about. Number one, the diagnosis is important, and how your laboratory, wherever it is and however you're getting your laboratory information, you need to be able to interpret the tests of toxin versus PCR, which is detecting the organism itself. And toxin testing is the more specific test, and we will see, I think, perhaps some backing off of strictly PCR testing. The other point for you to remember is that, and this will be new, that metronidazole is no longer a first-line recommended therapy for C. diff, and that vancomycin and fidaxomicin, of which I think vancomycin still will remain the workhorse therapy for C. diff, but fidaxomicin also needs to be considered, especially if there's high risk of recurrence.
Dr. Golan?
Well, I would agree. I would say only test patients with unexplained diarrhea. You don't have to ask the question, what's causing the diarrhea, if you know the answer already. And when you diagnose C. diff in a patient, always ask yourself, what's the patient's risk of recurrence? Recurrence has been one of the main, if not, I would argue, the main unmet need with C. diff, and it's very, very high. And use a strategy that will minimize recurrence in those patients at high risk.
Dr. Pardi, you got the last word.
Yeah, so 2 things. This maybe is a little bit of new data, but I think it's important to get it out there. For treating recurrent C. diff, if we're using vancomycin taper and pulse, we have some data that recurrence even after a taper or pulse is still about 40%. But it was a break at 6 weeks of total therapy. Those with tapers lasting longer than 6 weeks had about a 2-fold lower risk of recurrence than those treated with less than 6 weeks. So a taper needs to have a significant amount of time. And the second thing is the use of fidaxomicin. Yoav has some data, we published data, that it works better when you use it earlier in the infection. So recurrence rate in our study was 0 when fidaxo was used after the first infection, 20% after the first recurrence, and 30% after the second recurrence. Still lower than if we compared it to vancomycin, I'm sure, but the benefit is achieved earlier.
I want to thank all 3 of you for being here. I learned a lot. My metronidazole use is going to 0. And right now, starting today, I'm going back and spreading the gospel. And it's important stuff. This is an important infection. It's an important cause of morbidity, and it's a cause of mortality. And it's something that we're all going to be having to deal with in the medical community going forward, especially as our patients get older, patients get sicker, more of them get antibiotics. So on behalf of our panel, I want to thank you for watching, and I hope you'll join us again. I'm Dr. Peter Salgo, and I'll see you next time.